Now, when we diagnose hemorrhagic disease of the newborn, the disease is the commonest cause of bleeding in neonate. The baby will be usually well, complete blood count will show a normal platelet count, so he will have a normal bleeding time, but the PT is prolonged. Early in the disease, PTT is normal, but when the disease is severe, it will be prolonged, and clotting time is usually prolonged. Treatment is with a high dose of vitamin K, which is 5 mg intramuscular or intravenous. In severe cases, we give fresh frozen plasma 10 ml per kilo over 1 hour. This slide will show one of the presentation of neonates with hemorrhagic disease of the newborn. The parents will come with a diaper of the baby who have blood. It might be due to hematuria or bleeding the rectum. Now, if the neonate who is bleeding have a coagulation defect, but the baby is ill, which means that he is lethargic and not feeding well, we should think of severe liver disease or diseases like necrotizing enterocolitis, disseminated intravascular coagulopathy, and sepsis, or fragile blood vessels like hypoxia, acidosis, and prematurity. Usually in this scenario the platelet is normal, but sometimes it is low, like in necrotizing enterocolitis, and so the bleeding time will be normal or prolonged. But PT and PTT are usually prolonged, and clotting time is prolonged as well. Disseminated intravascular coagulopathy, or DIC. This is an example of a disease that will affect both elements of homeostasis, which means it affects platelet count, which is low, and coagulation profile, where it is prolonged for PT and PTT. Usually the baby is very sick due to a severe disease process like sepsis or severe hypoxia and acidosis. The baby will come with bleeding from any site like nose or GIT or hematuria, and usually a combination of multiple sites together with bleeding from puncture sites. Complete blood count will show a low platelet. There will be a prolonged PT and PTT with high FDBs or fibrin degradation products. Treatment usually involve treatment of the primary cause like sepsis and giving platelet transfusion and fresh frozen plasma regularly till the disease process improves. This means the sepsis will be cured. The second group of causes of bleeding in neonates is low platelet count or thrombocytopenia. In this group of babies, the platelet count is low, so the bleeding time is prolonged, but usually PT and PTT are normal and coagulation time is normal. These babies with thrombocytopenia might be a well baby. This means the baby is active, crying, and he is feeding well. The causes include alloimmune thrombocytopenia or autoimmune thrombocytopenia, like a baby of a mother of lupus, or there might be a weakness in the function of platelet, which is called thromboasthenia. The other half of the neonates who are bleeding with thrombocytopenia are ill babies or ill neonates. This means that the baby is lethargic and he is not feeding well. The causes will include sepsis, disseminated intravascular coagulopathy or DIC, necrotizing enterocolitis, or bone marrow failure. And again, the platelet count will be low, so the bleeding time is prolonged. Both PT and PTT are usually normal, but sometimes they are prolonged in combined process like DIC and NEC and sepsis, where both elements of homeostasis or prevention of bleeding are affected. How to manage neonates with bleeding? First, we have to reach for diagnosis. So we have to take a good history and do a good clinical examination. To reach for the diagnosis, we should ask for complete blood count, for the platelet count, and C-reactive protein to exclude sepsis. We should do PT and PTT as well as FDBs. If we found that the problem is in the coagulation limb, this means we have prolonged PT and PTT. The child might need vitamin K or fresh frozen plasma. If the baby have low platelet count, he will need a platelet transfusion. For diseases like hemophilia, usually we give the specific factor missing, like factor 8 or factor 9, or cryoprecipitate, and specifically treat the underlying cause like sepsis with antibiotics, DIC, or necrotizing enterocolitis. And this subject will be covered in more depth with the hematology lecture. The final part of our lecture involves neonatal screening. And screening means looking for a disease process in all neonates for an occult disease or a disease that is not symptomatizing yet. This means the baby looks quite well. We usually do this screen between day 3 to day 6 of life. And the disease that we are looking for should be a common disease with the serious consequences that mean that the neonate might die or become severely affected if the disease is not discovered early and treated. And lastly, the disease that we are looking for should be treatable. The test that we are doing should be simple, of low cost, and highly sensitive and specific. And an early treatment should affect prognosis, which means make the child normal or less affected. The diseases that we are screening all neonates for would include diseases discovered by clinical examination, like neonates with congenital heart disease, imperforate anus or congenital dislocation of the hip, or diseases that are discovered with laboratory investigation, which include inborn error of metabolism like phenylketonuria, galactosemia, endocrinal diseases like congenital hypothyroidism and congenital adrenal hyperplasia, blood diseases like thalassemia, and other diseases that might be considered in the future like cystic fibrosis, Duchenne myopathy, and deafness.